Today, I would like to discuss the effect of magnetic resonance guided focused ultrasound on patients with essential tremors with a low skull density ratio. We have no financial conflict of interest to disclose. MRgFUS thalamotomy has been known to reduce tremors in patients with essential tremors and Parkinson's disease. TSDR is considered a useful indicator of the effectiveness of this intervention. Specifically, the effect of this intervention has been considered poor in cases with an SDR of 0.4 or less. In Asia, including Japan, many cases with a low SDR have been reported, which can be difficult to treat. We aim to describe the result of our preliminary study on MRgFUS in patients with an SDR of 0.35 or less, and discuss the issues that we encountered in this difficult-to-treat group of patients. Among 100 patients with essential tremors who underwent MRgFUS between June 2019 and March 2022, 21 consecutive patients with an SDR of 0.35 or less were included in this retrospective study. 15 male patients were included. The mean age at the time of surgery was 67 years, and the mean disease duration was 23.5 years. We performed targeting as follows. We measured the pyramidal tract as a key landmark using a 3D cube tissue-weighted volume with a 0.5 mm thickness. The lateral coordinates were 2-3 mm medial to the thalamus border in the anterior commissure-posterior commissure plane. In our study, the distance from the third ventricular wall varied. As for the anterior coordinates, we measured the posterior boundary of the pyramidal tract as a landmark. Atlas-based targeting was used as a reference. We also used tractography and fusion imaging. Also, it is important to note that they are still under investigational use. During the procedure itself, we relied on the evaluation of clinical response. We carefully checked for numbness in the verification phase and then created lesions using temperature over 50. Treatment effects were measured using the clinical rating scale of tremor CRST scores at baseline 1 week and 3 months after the procedure. In addition, as one of the quantitative measures for evaluating performance, the distance of the tip of the pen when drawing a 150 mm line was calculated using a movement analysis software. This slide shows the sonication date. The mean SDR was 0.32. The temperature did not rise as expected, with the maximum noted temperature of 51 period 3 on average. In addition, the average lesion volume was small at 116 period 9 cubic millimeter. A large amount of energy was used, averaging 34,326 joules, while the average number of sonication cycles was relatively small. The day after the MRgFUS treatment, MRI showed that lesioning was achieved in 18 cases with temperature reaching 49 or higher. On the other hand, lesioning was not achieved in the 3 cases where the maximum temperature was 47 or below. After 1 week of MRgFUS treatment, 52.4% of patients showed an improvement of 75% or more in their CRST total score. Meanwhile, 19% of patients reported an improvement of 51 to 74%, while 28.6% reported an improvement of 50% or less. Lesioning was not observed in 3 cases. This slide shows a comparison of the CRST total score at baseline and after 3 months of FUS treatment. The pie chart on the left shows the result of 18 out of 21 cases, excluding the 3 cases where no lesions were observed. The pie chart on the right shows the result of the same 18 cases after 3 months. Here, we see that compared to the CRST total scores at baseline, 2 cases showed an improvement of 75% or more. 6 showed an improvement of 51 to 74%, and 5 showed an improvement of 50% or less. The CRST total score in one case became worse than that at baseline. The remaining 4 patients could not be followed up after 3 months because they were either far away or did not visit the hospital. In this paragraph, we observed a significant decrease in the score of all 3 parts of CRST 1 week after the treatment. This slide shows the changes in the CRST total scores at baseline, 1 week, and 3 months after the treatment. 8 cases indicated by the blue lines showed sustained improvement. 4 cases indicated by the green lines improved after MRgFUS treatment. These cases showed a recurrence of tremors 3 months later. However, their condition was better than that at baseline. 2 cases indicated by the red lines showed no change in the scores or worsened scores. 4 patients were lost to follow-up after 3 months. This slide shows the MRI of one successful case with the largest ventricle, which had a discrepancy between atlas-based targeting and MRI-guided targeting. The lesion was created adjacent to the pyramidal tract via MRI-guided targeting, and the tremor was relieved after 1 year. In contrast, this slide shows the MRI of a unsuccessful case where lesions could not be created. Also, we administered an osteoporotic drug for 1 year, which led to an increase in SDR. We still could not create lesions despite maximum energy delivery. Adverse events such as headache, numbness in the fingertips, and facial edema were noted. Most of these symptoms were mild or transient. However, one patient experienced finger numbness 3 months after the MRgFUS treatment. None of the patients had moderate to severe complications. In particular, 2 side effects were highlighted. The first was facial edema, which usually occurs within 3 days of the procedure due to the intensity of the energy delivered. The second is significant pain in the last phase of sonication, which is also due to the high energy delivery. To relieve pain, we used the 50 mg dose diclofenac sodium suppository 30 minutes before flame placement. Lidocaine, hydrochloride, and lopivacaine were also used as occipital nerve blocks. Dexmedetomidine was continuously injected during the treatment. We optionally used fentanyl citrate during the last phase of sonication. The main issues that we encountered were as follows. First, which cases required high temperatures for lesioning? Second, how should we perform MRgFUS in patients with low SDRs in terms of the location of lesions, volume of the lesion, and the strategy of temperature elevation? Our strategy involved including more elements to facilitate a rapid increase in energy, as well as a longer sonication time, which resulted in a successful increase in temperature and lesioning. We would like to highlight that we demonstrated a rapid elevation of energy to the maximum applied energy in patients with low SDRs, which is completely different from that in patients with high SDRs. In conclusion, even with low SDRs, Approximately 70% of the included patients showed an improvement rate of more than 50% in our preliminary study. Low SDR should not be considered absolute exclusion criterion for the application of MRgFUS for the treatment of tremors.